Welcome back to the Stroke Made Simple channel. My webcam is not working today, so we're going to do this without my lovely face. Remember, everything is contained within the book, Chapter 7. If you do value the content of these lectures, please be sure to hit the like and subscribe button and share these videos with your friends. So we're going to go ahead with our conclusion and our discussion of brain aneurysms. So most brain aneurysms, fortunately, are unruptured, asymptomatic, and found incidentally. However, occasionally, symptoms can result from non-ruptured aneurysms due to their mass effect on adjacent cranial nerves or other brain structures. For example, last time we talked about a posterior communicating artery aneurysm exerting mass effect on the third cranial nerve. When that happens, the outer fibers are involved. We get the classic third cranial nerve palsy where the eye is down and out. There's pupillary dilatation, and there is ptosis. Again, this is because if you look at this anatomy, here's the basilar artery. Remember, before it splits up into both posterior cerebral arteries, it gives off the superior cerebral artery. Coming off the posterior cerebral artery, and we'll go into this anatomy in greater detail later, is the posterior communicating artery, which communicates with the anterior circulation. Adjacent to the posterior communicating artery at the level of the midbrain, because this is where the oculomotor nucleus lives, is the third cranial nerve. So if the posterior communicating artery is dilated or aneurysmal, it can exert pressure on the outer fibers of the third cranial nerve and cause a cranial nerve third palsy, again manifest by pupillary dilatation, a pupil that's down and out, and ptosis. So symptomatic unruptured brain aneurysm should be treated. The problem is there's no established protocol for this. The problem is further compounded by anxiety of over a 50% mortality rate if those aneurysms do rupture. Now, there was a study called the International Study of Unruptured Intracranial Aneurysms. This was a large multi-center prospective cohort study which examined behavior of unruptured brain aneurysms. They basically reported a 5-year cumulative rupture rate based on the size and location of the unruptured aneurysm. However, there's a lot of criticism concerning this data that they procured from this study. For example, according to this study, the International Study of Unruptured Intracranial Aneurysms, small anterior circulation aneurysms less than 7 millimeters in size have a 0% 5-year cumulative risk of rupture. However, anyone in this field encounters ruptured aneurysms smaller than 7 millimeters in size. Other studies have shown higher rupture rates than the International Study of Unruptured Intracranial Aneurysms. Now, this is from the study itself. It shows the rupture rate. We're going to look at the anterior circulation here. Group 1 is no prior subarachnoid hemorrhage. Group 2 is prior subarachnoid hemorrhage. So in the anterior circulation, Group 1 patients, if they have an aneurysm less than 7 millimeters in size, they have a 5-year cumulative risk rupture rate of 0. Okay. Group 2, subarachnoid hemorrhage patients, have a 5-year cumulative risk of rupture of 1.5%. Again, this is less than 7 millimeters in size. When we go to 7 to 12 millimeters in size, that 5-year cumulative risk of rupture goes up to 2.5%. It goes up to 14.5% for aneurysms in the anterior circulation measuring 13 to 24 millimeters in size. And it goes up to 40% in giant aneurysms or aneurysms measuring greater than 25 millimeters in size. For the posterior circulation, you can see that the rates are high. The 5-year cumulative rupture rates are higher. In Group 1, again, no subarachnoid hemorrhage, it's 2.5%. In Group 2, where there's prior subarachnoid hemorrhage, it's 3.4% for aneurysms less than 7 millimeters. Aneurysms in the posterior circulation, 7 to 12 millimeters, have a 5-year cumulative rupture rate of 14.5%, 18.4% for 13 to 24 millimeters in size, and 50% for giant aneurysms or greater than 25 millimeters in size. So there's another way to try to determine rupture rate of unruptured brain aneurysms, and that is the phases score. This was a meta-analysis involving over 8,000 patients. And this score consists of multiple different components, including age, presence of hypertension, prior history of subarachnoid hemorrhage, aneurysm size, aneurysmal location, and geographical location. Each of these variables is assigned a point value, and they're all added together to determine a phases risk score. Like the international study of unruptured intracranial aneurysms before, this purports a 5-year cumulative risk of aneurysm rupture. And we add these scores up, the higher the score, the higher the 5-year cumulative risk of aneurysm rupture. So for example, if we're dealing with a 75-year-old man who resides in North America with no hypertension, no prior subarachnoid hemorrhage, a 9mm MCA aneurysm, we could determine their phases risk score. Because of his age, he's 75, he's greater than 70, he gets 1 point. Because he lives in North America, he gets no points. Because he has no hypertension, he gets no points. Because he's never had subarachnoid hemorrhage, he gets no points. Because the aneurysm measures 9 millimeters in size, he gets 3 points. And because of its MCA location, he gets 2 points. So this adds up to be a total of 6 points. When we look at this scale here, if we see the phases risk score of 6, this amounts to a 5-year cumulative risk of aneurysm rupture of 1.7%. Now, when we talk about treatment options for aneurysms, for both ruptured and unruptured intracranial aneurysms, the same 3 treatment options exist. The first is observation. So if you're dealing with an anterior circulation, tiny aneurysm, and the risk of this aneurysm rupturing is fairly low, that is much, much lower than the risk of treatment, you may choose observation. Another option, and the most established option, is open surgical clipping. Another option is minimally invasive endovascular treatment, which consists of endovascular coils and flow diversion. We'll discuss each of those in a little bit more detail. Now, how you determine aneurysm treatment depends on multiple factors, such as the patient's age, existing premorbid conditions, the location of the aneurysm neck to dome ratio, and the experience and confidence of the hospital staff in the ability to perform these procedures. Now, whether you're dealing with surgical clipping or endovascular coil embolization or flow diversion, we're dealing with the same 2 goals. We want the same 2 goals, and that is, and here's a picture of a coiled aneurysm, we want the aneurysm. It must be disconnected from the parent vessel. Okay, to eliminate this risk, we must disconnect it from the parent vessel. So that's the first goal. The second goal is maintain patency of flow, blood flow through the parent vessel, because if we don't, that could result in a stroke. So here we have surgical clipping where a metallic clip is placed across the aneurysm neck. Thus, we have accomplished goal 1, that is disconnecting the aneurysm from the parent vessel. And we preserve the patency of the parent artery, accomplishing goal 2. Now, open surgical clipping tends to have higher risk of complications, but has lower aneurysm recurrence rate compared to coil embolization. That's because you have to go through the skull to get to these aneurysms. Now, brain aneurysms will also be treated by endovascular methods. The oldest and most common method is still coil embolization, where we're going in through the leg or the arm and entering the brain using minimally invasive techniques. So when an aneurysm is coiled, we accomplish those same 2 goals, namely we disconnect the aneurysm from the parent circulation and we retain the patency of the parent artery. Endovascular treatment of brain aneurysms carries an approximately 5% risk of combined treatment-related fatality and morbidity. Now, these coils, when they come out, they have different shapes. The initial coil is typically something that looks like this. This is a framing coil. If you'll notice, as it's deployed, it forms this basket-like shape, so it can be held within the aneurysm. So thus far, we've discussed different treatment options, such as surgical clipping and endovascular coil embolization. And both of these options, notice we accomplished both our 2 goals, namely, 1, we disconnect the aneurysm from the parent circulation, and 2, we retain the patency of the parent circulation. Now, sometimes when you're dealing with wide-necked aneurysms, it's hard to keep these coils in this aneurysm. So stent-assisted coil embolization is also used. And in this matter, what happens is a stent is placed in the parent vessel to keep these these endovascular coils from protruding into the parent vessel. So these stent-assisted coiling techniques allows aneurysms to be retained within the parent vessel. It preserves this parent artery patency, and it prevents disruption of parent artery laminar flow. Now, sometimes aneurysms occur at bifurcations. Okay, so there's a Y-assisted stent technique where two stents can be used and deployed in each of these bifurcating vessels to maintain these endovascular coils within a wide-necked aneurysm. And here's one such case where we see, you could actually see this better on the non-contrast image. Here are the proximal tines of the stent. Here are the distal tines of the stent. This is a Y-assisted coil technique with the aneurysm dome coil embolized. This is a basal-tip aneurysm. Notice you don't see it here because it is completely coil embolized. Again, Y-assisted stent assisted embolization of this basal-tip aneurysm. Now, there are other endovascular techniques that we could use for embolization of aneurysm, and there are multiple flow diversion devices. These devices are either stent-like devices, the pipeline device, the surpass device, the FRED, or they're devices that actually fit in the lumen of the aneurysm, such as the Webb device, and we'll talk about that in a second. Right now, let's concentrate on the stent-like flow diversion devices. Now, these are not stents, but they're essentially placed across the neck of the aneurysm, and they divert flow away from the aneurysm lumen, causing it to eventually thrombose. So here's an image of the surpass device. Again, this is placed within the parent vessel, and it diverts flow away from the aneurysm lumen. This is the FRED device, again, placed in the parent vessel, diverting flow away from the aneurysm lumen. Now, these flow diverting devices have an increased metallic surface area, 30 to 50%, when compared to regular stents. If you look at a regular stent, there's not as much metal as on these flow divert devices. And the reason this is made this way is these flow diversion devices divert flow away from the aneurysm lumen, but it allows flow in adjacent perforator vessels. So it keeps perforators patent, but blocks flow into the brain aneurysm. So again, a stent has far less metal than these flow diverting devices, but these flow divert devices are made such as these interstices are the right size to redirect flow away from aneurysms, but allow flow to adjacent arterial perforators. And the reason that's so important is if we have vessels like a fusiform basilar artery aneurysm, there's multiple perforators coming off this aneurysm. So when we place these flow diverter devices across this aneurysm, we need to ensure that these perforators still can fill. In the same manner, if we drop a flow diverter device, and this is a periophthalmic artery aneurysm, across a wide-necked aneurysm, remember, coming off the supraclavian segment is the posterior communicating artery and the intracranial artery, and we need to maintain their patency, and these flow diverter devices allow us to do so. Now, this is a pipeline device, and again, you could see these interstices. It's kind of like a wired fenced configuration, allows flow to be diverted away from aneurysms and allows it to be maintained within perforating arteries adjacent to the aneurysm neck. This configuration might look familiar to you because it's very similar to this configuration of a slinky you probably saw as a child. And this flow diversion outside of the aneurysm but non-perforators might sound familiar to you too from your childhood. So essentially, whatever the device is, the goal is to place the device across the neck of the aneurysm, divert flow away from the aneurysm, allowing flow in the aneurysm to be attenuated, resulting in aneurysm shrinkage and thrombosis. Now, the Webb device is another flow diverter, but unlike the prior devices, instead of placing it across the neck of the aneurysm, this device is actually deployed through a microcatheter within the lumen of an aneurysm. And by doing so, flow is diverted outside of the lumen of the aneurysm, maintained within the parent vessels, causing these aneurysms to thrombose. Now, aggressive management is recommended in all ruptured aneurysms absent brain death. The minimally invasive nature of endovascular coil embolization makes it the primary treatment method for ruptured intracranial aneurysms. Now, there's a study called the International Subarachnoid Aneurysm Trial, ISET study, that showed endovascular coil embolization was safer than open surgical clipping. later, coil embolization of both ruptured and unruptured intracranial aneurysms was also determined to be safer than open surgical clipping. However, in this ISAT trial, although there's a decreased risk of death and disability with endovascular treatment, there's also an increased risk of re-rupture in the endovascular group. So while coil embolization will have a diminished risk of death or disability related to the procedure, there's also an increased risk of re-rupture in the endovascular group, the endovascular coil embolized patients compared to the surgical clip patients. So what does this all mean? What's going on here? If coiling aneurysm is safer than surgical clipping, should we just coil everyone? Well, not necessarily, because we just said coil embolization is associated with higher recurrence rates of these aneurysms. And the reason we believe these recurrence rates are increased is because these aneurysm coils can compact over time. And this compaction leads to the higher aneurysm recurrence rate when compared to surgical clipping. So this higher aneurysm recurrence rate must be considered when deciding treatment versus coil embolization or open surgical clipping. And why do these compact? Because if you look at this example here, this aneurysm looks like it's really tightly packed with these coils. However, this is only 27% packed, which is actually quite good for coil embolization. So that's where these flow diverting devices come in play, because like endovascular coil embolization, they have a low risk because they're also minimally invasive endovascular procedures. But like open surgery, they have a lower recurrence rate than coil embolization. And why is that? Well, here's before treatment, before a flow diverter is placed. Here's the flow diverter placed. You can see the aneurysm starts thrombosing. Sometime later, the aneurysm is thrombosing and shrinking. And now look what happens here. The flow diverter device itself, all those little interstices we talked about, they're filling with cells, which cause a barrier that cuts off this aneurysm. This is called endoluminal reconstruction, and it's basically endothelialization of the device's interstices. So we're reconstructing the parent vessel from the inside, and we're blocking flow to the aneurysm. So what's very interesting is if you look at open surgical clipping, why the risk might be higher, the recurrence rate is lower. Coil embolization has lower risk but a higher recurrence rate, and flow diverting devices have actually lower risk and lower recurrence rate and may represent the holy grail of future aneurysm treatment. You may have heard this before, but essentially flow diversion has lower risk and lower recurrence. So again, low risk and low recurrence rate. Low risk similar to coil embolization, low recurrence rate similar to open surgical clipping with these flow diversion devices. So in conclusion, we reviewed both ruptured and unruptured cerebral aneurysms. Ruptured cerebral aneurysms result in aneurysmal subarachnoid hemorrhage, which is a form of hemorrhagic stroke. It accounts for 3% of all stroke, and it has a very high mortality, unfortunately. Every successful stroke center requires a multidisciplinary team approach, which is certainly relevant for the successful management of aneurysmal subarachnoid hemorrhage. Aneurysmal subarachnoid hemorrhage patients unfortunately have poor probabilities of achieving a good functional outcome. That's why this multidisciplinary team approach is so important. These patients have devastating presentations, which typically involve complex management. Again, the team approach is essential to optimize every aspect of this horrendous form of hemorrhagic stroke. With that, we're all done. Remember, this is all contained within the book. If you've enjoyed the content of this lecture, please be sure to click the like and subscribe button as well as share it with your friends. Thank you very much for your time.